So let's start looking at hormone therapy and get a little bit into the nuts and bolts of actually prescribing hormones. So this is actually a screenshot out of that HIV Clinician Society guidelines, an amazing guideline that beautifully pulls it all together. And I'm going to go through all these steps, so don't worry about all the little blocks, but basically it's very easy. You're going to have a discussion. When we talked about informed consent, we did that in detail. Then you're going to do a baseline assessment on your patient, like we do before we start any treatment. We're going to initiate therapy, and we're going to go through those 2 therapies. And then we're obviously going to monitor our patient once we've put them on hormones. So this is our discussion, and this is again from my informed consent, and I'm just going to go through the headings. We're going to talk about the risks of benefit for that particular medicine you're going to give. We're going to talk about what's reversible and what isn't. Important conversation. And remember, we have changes. So how long will it take before the change start? What's the timelines that you can expect? And very important to manage the expectations. I'm not going to be able to give you a massive pair of breasts or a huge beard. It depends on your genetics and how your body will respond to those hormones. We need to have a conversation around reproductive options and talk about things like adoption. You can see I am re-emphasizing that repeatedly. Great, but that we've talked about in detail. Now we have to do our baseline assessment, and it's similar to taking a history for contraception. So if you think in terms of putting people on contraception, or if you are men that you are treating with low libido with testosterone, it's the same things. We want to look at stuff that might be excreting hormones like livers and kidneys. We want to know about cardiovascular disease and blood clots because that might be important. They have relationships to hormones. We want to know about malignancy, especially if it might be hormone-sensitive malignancies. We want to know about cholesterol, diabetes, and any other metabolic or endocrine conditions that might be relevant. So very similar to our contraception history. And not only in the patient, but also a little bit what happens in the family. We obviously want to know what kind of surgeries they might have had in the past, and we want to ask about allergies. So very much your box standard normal medical history. Then when you do your physical examination, very important, there's no reason, the same as for contraception, you don't routinely now have to go and do a breast or genitalial examination. It's only if there is something the patient is concerned about that you might want to do that. Please be very trauma aware and very careful in consent and very much explaining what you do as you do it. So this is from the HIV Clinician Society guideline, and you can see if you've got money, then these are the things you can do. But if you don't have money, which is our setting, and I'm never convinced that we have to overdo it, we want to do an hemoglobin at the beginning, more important in our trans men especially, who's going to go into testosterone. We want to do a creatinine, always good to know what the kidney function is doing when you're starting treatment. Because our hormones are processed by the liver, we want to know what the liver is doing, so we'll do an ALT, don't need a full LFT. You can do a finger prick glucose just to screen for diabetes, just generally sensible. And then, yeah, you can do a total cholesterol and HDL at baseline, slightly over the top on a 19 or 20-year-old, but it's good to have that on record for future reference. Just in case there's somebody with a familial hypercholesterolemia. And then, of course, because we are very much within sexual and gender health, always hangs together, you're obviously going to make sure that you've got your recent HIV and hepatitis B serum antigen testing, that your syphilis testing has been done. And very important, if you have somebody who was assigned female at birth, make sure you don't do a pregnancy test before you start hormones. So now we're going to look at the actual preparations. So for feminizing gender-affirming healthcare treatment, you want to choose the right preparation. And we've mentioned, and when we gave the overview, is that parenteral gender-affirming health hormone therapy is definitely better than oral. So we don't have that at the moment in the public sector. So the oral GAHT always requires an anti-androgen, which in our setting is spironolactone. There's some things about progesterone. So progesterone doesn't actually have much feminizing effects, but there are some interesting things that people are doing around micronized bioidentical progesterone. We don't have those, but certainly we use like progesterone quite happily in trans men to suppress periods. So yeah, we don't routinely use progesterone in our trans women. Our focus is only going to be on the estrogen for those particular changes we want to get. So risks and side effects of treatment. So we've mentioned these, so I'm just going to go through these very quickly. So the side effects, we want to tell them, remember, you're going to go through puberty. So headaches, just like contraception, can be a bummer. And especially if they have somebody who's had migraines or headaches before, you should watch out for those. Mood changes are usually not a problem, similar as all teenagers, but if you've got somebody who is very emotionally labile and anxious, they might need a little bit of extra support and a bit of extra watching as they go through it. And then we've talked about those changes to the sexual response cycle, very important, how that might change. So feminizing treatment is going to suppress the testosterone. They're definitely going to have some reduction in spontaneous sexual desire, but that doesn't mean sexual desire will go away. Contraindications is if they've had DVTs in the past, as I've mentioned, and if there's active liver disease or an estrogen sensitive cancer. And these you are going to have to discuss with an endocrinologist. And then again, the challenge is more if we've got our older trans women where we are worried about the risk of thrombosis and clot formation, where they might already have risk factors for things like stroke or DVTs, then that's going to make us a little bit more nervous. And it's similar to our women on contraception. So we need to watch those. And so one of the big things you'll definitely be advising your trans woman on is not to smoke. If they want to stay on their hormones, they need to be able to stay as healthy as possible and reduce that cardiovascular risk. And then infertility, obviously, we've talked about that repeatedly. So because we are giving hormones and because there's always this potential risk for things like clots, we do want to know what the modifiable factors are. So we want to know what's going on with their diet, their weight, do they have metabolic syndrome or not, and then, yeah, smoking. And especially if they're more than 35 years old, we want to start looking what's going on with that family history. Are there other risks I need to be considering here? So these are our preparations. So the two I'm going to spend time on, I'm not going to talk much about Premarin. So Premarin is not, it's okay. It's not great. It does do the job. It's got more side effects as well, not quite as effective as Estrofem. But Premarin has been very available in the clinics, and there's been a lot of black market use of Premarin. So you might have trans women who's used Premarin in the past, finding it like as, getting somebody to buy it as contraception and using it as using the contraception dosing. But we do have Estrofem in the public sector. It comes as a 1 milligram tablet, and it's usually used for our postmenopausal women. So that's why the medicine exists, and it's actually a level 1 medicines, which means it can be dispensed by a clinic. So we've mentioned that the use of these medicines for gender dysphoria is actually in our tertiary EML. So if you have an expert prescribing it, a person who's, and you guys are all going to become experts, if you've got some mentoring, for example, with a family physician like myself, if you're prescribing the medicines in a place like Corsten Clinic, the clinic is actually able to order that Estrofem and the spironolactone we'll talk about in a minute through the primary healthcare system, because the medicines, it's a bit like if you have a doctor coming to do, like you've got a psychiatrist that does outreach to your clinic and provides medicines that's available in the tertiary EML, but they're level 1 drugs, so they can be ordered by your clinic. So we typically start with a 2 milligram dose. And typically the easiest is just to go up with a dose every 3 months. So it's like puberty. We're not going to rush things. And the problem is if you go up with the dosing too quickly, you're going to have a lot more of that acne and mood changes. So we're going to go up very slowly. And most trans women will end up between 4 and 6 milligrams a day, and usually about a maximum dose of about 8 milligrams a day for that Estrofem. Very, very simple dosing. The other option is our estradiol, and so this they like to use in the private sector. It comes in a 5 ml vial, and you can see actually this 5 ml vial lasts for quite a while. So this is not so easy to get at the pharmacies, but there's a compound pharmacist online compound pharmacy called Fagron, where you can order the estradiol with a private script. And I do have the odd patients. For example, I've got patients who's traveling from places like Queenstown to East London to try and access treatment. And the one trans girl was not really liking the spironolactone all that much. And so we was looking at, well, actually, if you look at the costs in terms of her traveling to East London, it's actually cheaper for her to be on the estradiol. It lasts for a good 6 months, and then she can come in every 6 months just for a script. So I have been prescribing these even in the public sector. So you start also with that 2 milligrams a week. It's literally 0.1 mil. It's a very small amount of fluid. You give it subcutaneously, so you do it just like a diabetic, so they can give it themselves. It's lovely little videos that we give them to show them on how to do it. And every 3 months, you go up by 2 milligrams. And again, quite often 6 milligrams is plenty. And you have a little bit more potential to go up to higher dosages here. The guideline says as much as 20, but usually 6 to 10 will do the trick. And you can also, if people find they feel a dip, like, the week doesn't quite seem to last them. Some women have a real experience of how the estrogen affects them. Then you can actually shorten that weekly interval. There's also a patch. For those who don't like injections, it's got the same advantages as the injection. I don't have much experience with this, I must say, but it's quite expensive. So the estradiol is much more affordable, and therefore is a great option. And then, so we have to, if you're giving the oral estrofem, you have to combine it now with an anti-androgen. And we do have spironolactone available in our facilities. The other option is cyproterone. Cyproterone, I don't know how you pronounce that. You can have that in the private sector. So spironolactone, there is a risk of hyperkalemia. The risk is very low in our healthy young patients. So spironolactone, we normally use it in patients with heart failure and hypertension, and then we're quite nervous about hyperkalemia because a lot of them has got kidney problems as well, and they're fluid overloaded. And but here we just need to do that potassium, but you don't have to do it quite as soon as we do with our heart failure patients, or especially our kidney patients, where you have to monitor the potassium very closely. So spironolactone, we're actually using it for its side effects. So we know with, for example, people with heart failure, so men with heart failure, if you put them on spironolactone and you're using high dosages, there's a risk that they can develop gynecomastia. It suppresses the testosterone, and then your natural estrogen could actually start overproducing and lead to development of breasts. So we're using spironolactone for its side effect of suppressing testosterone. And it can cause some gastrointestinal things in some of the patients, although we don't see that very often. So we use higher dosages than we do for the heart failure patients, somewhere between 50. A lot of them are usually on about 100 milligrams. So you start off by 25 to 50 milligrams. Again, if you've got a young, healthy patient, you can easily start on a 50 milligram dose. So if you start that, well, you can start on 25, and then after 2 weeks, you put it up to 50. So that after 1 month, they're on a 50 milligram dose. You'll check if the potassium is all right on that 50 milligram dose. And then after that, you can monitor them in the beginning 3 monthly, and eventually 6 monthly will be fine. I've got a little on the bottom here. This is the prices as of recently, meaning the prices as of would be recently on the latest tenders that's currently on the do you call it, on the system in the public sector. But of course, tenders change and shift. So we haven't ordered any recently. So this prices might be slightly different, but it gives you ballpark figures. So this tells us, so a packet of estradiol costs about $43. So if we look at how much the monthly cost will be if somebody ends up on that 4 to 6 milligram dose eventually, it's going to cost the government about $170 to $260 per month. And then the spironolactone that we always combine it with is, again, if they're going, that's only $25 for 50 milligrams, actually. Again, we're going to end up on 50 to 100. So there's your monthly cost. So basically what feminizing hormones will cost the public sector, and this, the pharmacist is always interested in this, is between about 200 to 300 Rand a month. And interestingly enough, the estradiol subcut would be much cheaper. So it is a question whether that might not be a better option on the long run, and also a safer drug. So if we talk about masculinizing gender-affirming healthcare treatment, we now want to promote virilization. We can't use oral testosterone. There are some oral testosterone preparations. I don't know very much about them. And then so the testosterone is the one medicine you use. And then some people might still spot on that testosterone, but you also get some patients who's quite happy with social transition. They're quite happy just to bind, socially wear masculine clothing, but they find the periods very dysphoric and very difficult. And so the mini pill, if they tolerate that quite nicely, you can also get an IUD, and the Mirena IUD that just clears up the periods, and you pop that in every 5 years. And this is a very nice option. It doesn't have any feminizing effects, and there's a lot of our trans boys that are quite happy just to not have to worry about periods. You can obviously also do the Depo-Provera. Depo-Provera is getting a bit of a bad rap in terms of long-term use, even for contraception, with things like potential for osteoporosis and the meningioma is very, very low risk. But yeah, most of our data on the Depo-Provera is actually for 2-year use. So if they are able to manage a mini pill every day, that's probably a better option, or the IUD is a very nice option with some local. You can also use fancy things like leuprolide, very expensive, and anastrozole, a bit overkill. I think most of us will settle with the easy options. So for your testosterone, as we've mentioned, acne is always the pain in the butt, as all teenagers. So that's something that one has to manage, like you would manage acne in teenagers. Mood swings, aggression gets a bad rap for people on testosterone, but it's a little bit like the sexual desire. Not everybody on testosterone becomes aggressive, just like not all big men that has a lot of testosterone, like, your muscle builders, for example, will have more higher levels of testosterone. Sometimes it's linked to aggression, but sometimes not at all. So it's a little bit, but what you do find is they might be a little bit more on edge than they were before they went on treatment. And just like teenagers, that will eventually settle into what is normal for them. And then they might start balding. Some trans men really like it when the hairline recedes slightly, because it gives them more of a masculine look. So for some men, that's actually a bonus. So the complications we're worried about, because they now have the same risks as our cisgender men, is hypertension and high cholesterol, just like the guys have got. And then, the interesting thing, one is they can make too much red blood cells. Like they might have to become a blood donor, which is a very easily manageable complication or side effect. Testosterone can, again, not seem much hepatitis, but in theory, all of the hormones can affect the liver. And again, infertility is our big conversation. If you're years and years on testosterone, it's definitely going to eventually affect the permanent functioning of the ovary. And then you obviously not give it in pregnancy. That's a major problem. You're going to end up virilizing that fetus. So you have to have a pregnancy test before you start it. You have to make sure they are on contraception and not just rely on the testosterone as a contraception, and make sure that they have active sex hormone. If they have, just check that, if there's a active sex hormone, if there's a cancer that's sensitive to testosterone, then you're going to have to refer to an endocrinologist for conversations around that. So testosterone, we have 2 preparations. So we used to have this Nebido, which is every 10 to 12 weeks. And there's some patients who, they got used to Nebido. They quite like that. It's expensive though. It's it's like 1,500 or 600 Rand for a 3-monthly injection, but it is a bit of a, if you have to pay that out every 3 months, it's quite a bit of money. You can shorten the interval slightly. So it's a standard sort of big injection that you give intramuscular. It has to be given intramuscular, and you can shorten the interval if need be. But what's much nicer is the testosterone cypionate. It's made by Pfizer. So they were out of stock for a bit while they were making vaccines during the COVID time, but it's back in stock. If you buy it privately, you pay about 600 to 700 Rand for a vial of testosterone cypionate, but you can shop around at pharmacies and online pharmacies to get a good rate. The thing is, this vial, it's a 10 ml vial, and it literally can last you at maximum dosages. If you're on the highest dose, which is sort of 1 ml per week, then that will last you for 10 weeks, which is 2.5 months. But you actually start with much lower dosages. So you're going to start with 0.5 ml a week. So you can give it IMI, but everybody does it subcutaneously. It works very nicely subcutaneously. And you can even start in a lower dose for people who might be very sensitive to hormones. And then you're going to increase by 0.1 to 0.2 mils every 3 months. So you're going to go up in very small increments. And 0.5 to 0.8 mil, most men are very, very happy on. And usually you'll end up on that 100 milligrams every week. Some people do it 200 milligrams every 2 weeks. So that's like a 2 mil subcut injection, which is a bit more heavy duty. But I find the week is quite nice. It gives a much smoother ride. Otherwise, people start feeling that dip towards the end of the 2 weeks. And I always say to my patients, if you think you're poor diabetics who inject themselves, 3-4 times a day, this is not such a hardship once a week. And your maximum dose is usually sort of 1 mil subcutaneous per week. Oh, sorry, there's the pricing. More interesting. So in government, the depot testosterone has to be provided through the tertiary hospital. So the primary healthcare clinic can't order it. So when we were talking, for example, to one of the tertiary hospitals, they were happy if it is being prescribed under a center of excellence by experts that are prescribing that testosterone. They can then down refer the vials to the pharmacy, which can then be dispensed at the primary healthcare clinic. And you see it costs 164 Rand for that 10 ml vial. And as I've said, that can last a good 2.5 months or even longer, about 3 months if you are using the 0.8 mils. And so monthly, it works out to roughly about 50 to $60 per month. So very, very cost effective. So the ideal world, and I've actually started looking at that in public sector, and it looks like it is possible in public sector. Ideally, what you want to do is to be able to find out exactly how much hormones is good for your patient. It's amazing to do treat to target. And then you can use hormone level monitoring. And you're not going to take any hormones at baseline, and you're not going to monitor hormones long term. It's literally just until you've got them on a dosing that gets them to the cisgender ranges. So what you do is when you fill in your NHLS form, if the patient's on feminizing hormone treatment, so she's a trans woman, you're going to circle the female, and then they will give you the physiological cisgender female ranges. As a matter of fact, they will tell you what the estradiol level is for the different phases of the menstrual cycle. If the patient's on masculinizing treatment, then again, you're going to circle that male. And then when they send you the result, they're going to give you the cisgender male ranges for testosterone. And that's basically the ranges that you want to aim for. You do not want to give hormones where the patient is over and above the physiological range. And this is especially important with feminizing treatment. This becomes very important because if you've got high levels of estrogen that's giving more estrogen than is needed, you're not going to get more effects. You're just going to get more risks. So from a safety point of view, we want to keep them within that physiological range. And for the masculinizing treatment, the problem is if you've got too much testosterone in the system, is your body turns it into estrogen. So that is why sometimes bodybuilders takes testosterone to build muscles, end up developing breasts, which you definitely don't want to have. So it's important to not aim for the highest levels you can. You want to get them into those ranges. You can, because remember for our ladies who's on spironolactone, it's sometimes helpful to know, is this dosing of spironolactone actually suppressing that testosterone? That you'll do as a one-off. After they've been on treatment for 9 to 12 months, you can just check if that testosterone is now in the female range. I'm going to be sending all of you a handout on gender affirming healthcare to just give you an idea of with all of this information on it to refer to. It's also all in the guideline. So with the monitoring, as I've said, you don't need to monitor the hormone level. So now when you go and look up at when you should do the level, it depends on what you're doing a level for. So some people are very much trying to see, can I get to this physiological range? For me, the issue is safety. For us as doctors, we need to make sure the patient is safe. The patient needs to make sure they're happy that the dosing is creating the changes they want. I want to make sure that my patient is safe. And so I want to know what the peak levels are of that particular hormone. So if they're on an injectable, so for example, whether it's estradiol or testosterone, about 2 days after they've done their injection is a good time to do the levels. they're taking their oral estrofem in the morning about 3 to 6 hours after the dose. So you don't want to end up taking it just before they have their injection, because then you're not sure how high those levels actually get. So that's when you want to do your hormone testing. You're going to do a hormone testing at 3 months when you start, and then at 6 months, and then at 12 months. And once they're on target and they're in that physiological range, you don't need to do the hormone levels again. So it's actually, we don't have that many patients on hormones. So from a cost point of view, in terms of the overall cost to the public sector, it's actually a very low cost. So there may not be hormone level monitoring where you are at. I haven't had problems so far. But in those scenarios, what you do is you're going to aim for the lowest dose that the patient feels comfortable and happy on, and it has the fewest side effects. So again, we're thinking safety. So you don't need to try and get them to the maximum dose. If your patient is very comfortable and happy with the changes that they are experiencing, and the body is starting to go through that second puberty, then you can just focus on doing those safety monitoring bloods. We'll talk about those in a minute. We'll talk about this now. So at your review visit, every time you see the patient, basically is going to be 1 month after you've started the treatment. Sometimes you can even just do it at the 3-month visit. And every time you see the patient, just like with contraception, you do your weight, your height, your BMI, your waist circumference, and your blood pressure. And then you're going to do your safety bloods at 1 month on treatment, 3 months on treatment, 6 months, 1 year, and then annually. So a system that I have with my clinic anyway is that which we do at Family Medicine Outpatient Department. So we've got bloods that we do for our diabetics and hypertensives in the public sector. And what I do is I've got a little cover page that we fill in. So I would work out, okay, my patient's coming back in 3 months on the 28th of January. Then I give them a little page that says you're going to go for a blood test on the 21st of January. I ask them which clinic is the closest to them so they can go to their own clinic for the blood test. You fill in the NHLS form, and you can write on the top of the form the facility through which the bloods are. So if, say, for example, the COE Corsten Clinic is running that service, then you would write Corsten Clinic as the clinic who's requesting the blood tests. You would tick the blood test that you need. You'll take one of your little barcodes, put it in your clinic file. You give the patient the NHLS form with the cover page, and I put it usually in the plastic ready. And then I said to my patient, this is your appointment letter. This has saved us a lot of time in our clinics where patients don't come back after 3 months. The intern sees them, does their bloods. Now they have to come back again for the results. So basically, when you see your patient in 3 months' time, they've had their bloods done a week before. This works very well if your patients are scattered over a large district. And then you've got the results, and you can make a decision in terms of what you want to do with a hormone therapy. So for feminizing treatment, because they're on spironolactone, you want to do that creatinine and potassium and an ALT. Very easy. And then if they're on masculinizing treatment, remember, you can have that challenge of the polycythemias. You want to do the hemoglobin and an ALT, very easy. And then if your patient has any reason that there's risk, so they're more than 40 years old, or they've got a metabolic syndrome, then you might repeat your total cholesterol and triglyceride, but we don't have to do those routinely in young people, similar to contraception. So I've got a few practical tips in terms of getting the job done. And this is just in terms of the injectables, for example. So Fagron is this compound pharmacy, and you can get compound versions of both the estradiol and the testosterone. With testosterone cypionate, it's about 500 Rand for a 10 ml vial. So it is a little bit cheaper than the 700, 800 Rand you would pay at discount for the Pfizer version. So for some patients, that might be worthwhile if they want to just save an extra $200 or $300, and that's going to last them 10 to 12 weeks. And as you can see, we get it much cheaper actually in the public sector. But estradiol is probably more often the one that you might want to use. You might have a patient in the public sector who goes, either you're having problems with the spironolactone, for example, or they're finding it difficult to travel vast distances, and then giving them a private script for something that's going to last them 4 to 6 months actually becomes very economical as well. And again, as it says, I'm either, but both of these you can give subcutaneously on a weekly basis, which is very easy. So they can be given subcut. I've got some lovely videos. We'll send a pack round to all of you that will have links to all the videos on how to do a hormone injection. Usually, if you can find a 1 ml syringe, I struggle to find 1 ml syringes. So what I've done for my clinic is I make them a little pack. I've gone and bought in bulk the syringes. There's usually 2 ml syringes that works quite nicely. And then I buy 2 sizes of needles. So the 18G needle is that big green one. And because the stuff's in quite an oily base, it takes forever to draw up if you use like an insulin needle, for example, or a small needle. So we use a 2 ml syringe. We use an 18 gauge green needle to draw it up. And then you change the needle to whatever you can find. So I find Dis-Chem does have the 27G needles. It comes as a 27G, they call it a 0.5-inch length. And that's what it looks like. It's a little gray needle. And then, so all they need is they need a little web coil, they need the syringe, they need the big needle to draw up, and then they need the little needle to actually do the injection. What does also work is BD Microfine has got like a little insulin injection needle pack where it's got a 27 mil needle on it, and it's a little 1 ml syringe. So it's very nice for you drawing up 0.1 and 0.2. But I must say the stuff's very oily. So you literally sit there for like minutes waiting for your syringe to fill up to even just 0.1 or 0.2 mil. And a pack like these is more expensive. They're like $250, where these disposable needles are like $40 each. So there's I've worked it out. It costs me, I can sell them to my patients for 10 Rand a month to give them all the needles, syringes, and things they will need. So they usually buy for $60, they get 6 months of supplies for all their injectable needs. So that's just a practical thing. You might find that some of these needles and syringes you actually have available in your clinics. And again, it's only 4 syringes a month, 4 green needles and 4 gray needles. It's not a huge amount of stock that you have to give out. It's not like the diabetics. So yeah, so this is, for example, some of the links about how to do a subcutaneous testosterone injection, but it's pretty much, we know the drill like we do for diabetics. And remember, talk about what they're going to do with those sharps afterwards. So like with our diabetics, I always recommend using, for example, milk bottles or Amasi bottles. It's got a nice big enough lid that you can pop your syringes and needles in there. And then that can be closed when it's full, and you can just bring it to the clinic and you can dispose it with your usual sharp bins, just like we do with the diabetics. So what I thought I'd do now, just to make it practical, and just checking in the chat